All right. So if you recall from chapter 8 in CNA, okay, it's kind of like a little review, the anatomy of the gastrointestinal system. It's composed of obviously your mouth is part of it, your your teeth, okay, your teeth, your saliva, and everything that is in your mouth is part of your GI system. So your mouth plays in a very important role in the mechanical breakdown of nutrients. So whatever we put in our mouth to consume, to eat, has to be broken down first in your mouth, right? So your teeth help you with mechanical breakdown. And then the saliva is very important because it provides some enzymes. There's some chemicals in there that help you, of course, not only make that food into, like a, just like a, make it like more liquid, but it helps break down the food into smaller particles. So when you're chewing your food, okay, saliva starts coming in here and it becomes a little mush, right? And then you swallow it, it goes back down into your esophagus. Esophagus is that, that tube that connects your mouth and your stomach. Inside your esophagus has, we call them rugae, or in Spanish we could consider them arrugas, right? They're just like foldings that is inside your esophagus. And it also has a movement called peristalsis. Peristalsis is the inner movement of your esophagus in a downward direction. Okay, your esophagus helps food move along right down into into your stomach. Before it enters your stomach, there's an area called the a sphincter. Okay, we have a sphincters or muscles that close. We talked about urinary sphincters the other day, anal sphincters. Well, in your esophagus, we also have sphincters that help keep food in your stomach and not necessarily come back up. All right. So this is very important because as we get older, those sphincters loosen up. Okay, they get a little weak, and eventually we may have problems with reflux. You see this reflux problem with a lot with like heartburn. People complain of heartburn, or sometimes it's confused as chest pain. So if that sphincter is not working properly, you're going to have a lot of reflux coming back up. All right, and this we see this very commonly. Okay, now once the food makes it into your stomach is a very complex muscle. Okay, it's a pocket, but it's also muscle. Your stomach is stimulated by the vagal nerve. It's automatic. Okay, we can't stop it. It just continues to churn. What it does, it's like a little you call it like a little washing machine, right? It churns. That's the term. It moves around. Okay, but it also produces gastric acid. Gastric acid is very strong, and it helps to break down that mush we had in our mouth that we swallowed. It helps it to even break down into smaller molecules, smaller molecules. So at this point, the food that you're eating just became more, was broken down into smaller particles, so that once it makes it down into your intestines, your body is able to absorb all the nutrients, okay? Remember, most of what we eat is waste. Your body only takes your nutrients, like your electrolytes, sodium, potassium, magnesium, and so on, but also your protein, your sugar, your fats, okay, your cholesterols, everything that your body needs is going to take. It's the only thing it takes in. So we produce a lot of waste. So a lot of what we're eating really is just a bunch of poop. Okay, so it's important that you remember that we're eating to stay alive, right? We live to eat, or we sometimes we overeat. Anyhow, so your stomach is going to churn. Okay, it's going to turn that mush into smaller particles. And then at this point, guys, in your stomach, there's a lot of other organs that are start working. Okay, one of them is your gallbladder. Okay, your vesicula. A lot of people have problems with this, in the long run. Your gallbladder produces what they call bile salts. Okay, it's another liquid that helps you digest or intake your fats. Any food that is fatty, it will be absorbed or help in absorption with the bile salts. Okay, so we see a lot of people that experience gallbladder problems or gallbladder pain and end up having their gallbladder removed because they eat a lot of uh, fatty foods. Well, it's not so much the fatty foods, it's that your gallbladder, what it does is that every time you eat something fat, okay, your gallbladder produces more and more bile salts, right? So what happens when it produces too much? Well, those salts will turn into little rocks, okay, very, very small rocks that will eventually start to occlude the little duct. There's like a little duct, right? There's your gallbladder, and then the little tube that connects it into your intestine, right? So all those little rocks are going to come in and they're going to block that little tube where it drains into your small intestine. So what happens is that now the bile salt cannot empty into your small intestine and it backs up into your gallbladder. Now you have swelling occurs. Swelling becomes very painful. And of course, people complain of pain on the right upper quadrant, right below the rib cage or around your liver. That's where people start complaining of pain. Okay, and that in this case, it may be because of your gallbladder that's swollen. Okay, we call it coli. Coli means gland. Cyst. I'm sorry, coli means I forgot what it means. Cyst is a gland, and itis, of course, is inflammation. So inflammation of your gallbladder. All right. Most commonly, it's going to have to be removed surgically. So if you ever experience pain like this after a heavy meal, perhaps a fatty meal, you might be experiencing cholecystitis or inflammation of your gallbladder. Any questions on that? So I'm kind of giving you a real quick breakdown of the GI system, okay? So you have your gallbladder, you have your stomach, and then you also have a pancreas. A pancreas is a big gland. It's an organ that helps us in digestion. It has a lot of functions. Number one function is to produce insulin, right? It produces insulin so that we are able to utilize the sugar that we eat. Remember that mostly all the foods that we consume are turned into glucose, okay, usable energy. Your body uses glucose. We don't use, your body doesn't eat the table sugar. It doesn't, it doesn't consume sucrose or galactose from milk or anything like that. It turns it into glucose, and that's what we need. So anyhow, your pancreas will start working at the same time you're eating. Okay, so if you eat something for breakfast, your organs are already awake. They're starting to produce all these chemicals. If you ate sugar, your pancreas is going to produce some of the enzymes that will help you absorb that. Okay, we have lipase. It helps us absorb fats. We have amylase, which helps us absorb some of the sugars. Lipase, protease, which helps you absorb some of the proteins that you're eating. So again, so now you got your gallbladder and you have your pancreas, you got your stomach all working together so that whenever that mush, all right, that breakdown uh, goes into your intestines, now once it's in there, we call it chyme, CHYME. That's what semi-digested food is called, okay, chyme. People call it vomit, but it's called chyme. All right. So once it makes it into your small intestine, okay, it's into the first part of your smallest intestine. It's called the duodenum. All right. You can look up this anatomy perhaps later on, but the duodenum is the first part of your small intestine, and then you have a second part which is called the jejunum. Now, why do I tell you these parts? Because there's going to be some tubes that are inserted into these parts of the body for feeding purposes. So that's why you have to be a little familiar with the anatomy. So again, remember your stomach has sphincters, one at the top by your esophagus where it connects, and then it also has another one where it connects to the duodenum. Okay, or some people call it duodenum, but it's called pronounced duodenum. So, and then of course it continues on to your jejunum, and then it just becomes your small intestine. The most people have an intestine, a small intestine. It's about 20 feet long, so that's a lot of intestine, and it's for the purpose of absorption, right? So all that time that is going through your small intestines, traveling up and down and sideways, and at this time, all the nutrients, whatever it is that you were consuming, is getting absorbed by your body. Okay, and all those nutrients are going to every single cell. So If you remember the last time that you sat down and ate, a good heavy meal, maybe in a holiday like Thanksgiving or something, how did you feel after you ate that food? How did you feel, Norma? Do you remember the last time you had like a lot of food, and how did you feel?
Super full.
Well, and then you feel a little bit sleepy.
What was that, sir?
Do you feel a little sleepy?
Sleepy?
Yeah, like drowsy.
Yeah.
Okay, why does that happen? I personally don't like that feeling. I don't like to feel like sleepy or dragging or like, oh, I got to take a nap after, I pigged out. And now I'm sleepy. In your intestines, there is a lot of circulation going there. Okay, there is a lot of circulation that goes down there. So when you start eating, blood flow moves from your arms, from your distal, from your arms, and it goes down there so that all the nutrients can be absorbed. Okay, so once you start getting sleepy, you start to get a little colder, because circulation not just moved down there to your intestines. So we call it a food coma, right? Like you start to get sleepy and you want to take a nap. That's usually when we overindulge, right? If you eat too much, you're going to feel that way, right? So that's part of the reason, because of the circulation changes that happen. So again, your intestines main job is to absorb all the nutrients. And then, of course, later it moves down into your large intestine, the large, or the colon, call it. Okay, there's four sections in the colon, where the small intestine and the large colon meet. There's a little appendix. You might have heard it. The appendix. It's a little, um, you could say, kind of like a little stop. I don't know, just a little gland, right? The appendix is, now we know that it plays a major role in your immune system. So if you ever get an infection, okay, in your intestines, that that appendix will help you fight off infections. But many times, it pays a price. It gets swollen, and now you have appendicitis, right? Appendicitis pain usually happens in the right lower quadrant, okay, very close to your umbilicus on the right side, more like on the groin area. And if you have pain down there, you might be experiencing appendicitis. All right. So the large colon, the job of the large colon is to make sure that it absorbs the water, right? So if you're eating and drinking water, fluids, whatever it is that you're drinking, your large colon is going to absorb that water. Okay. So imagine the waste, okay, all the waste that was coming in your small intestine, it's chyme, or it's not chyme anymore, it's just waste. It's moving down into your large colon. What's going to happen now? The colon starts to suck the water out of that waste, all right, brings it into your circulation. So now your body has more fluid in it. So it brings all that. What happens to the waste is starts to dry up and starts to take the form of your colon, right? It has we have an ascending colon, and then we have a transverse colon. So it's up, transverse, and then we have a descending colon, right? So descending colon, and then it's going to fall into a pocket called the the rectal pouch. Okay, that's where the stool, right, the waste is already formed, and it stays there until you're able, or you're wanting to go evacuate. Okay, you go and you relax your sphincters, and there it goes, out it comes. Okay, so it's a process, guys. It's a process, very important process that we take for granted. We stuff ourselves every single day. We're eating and eating and eating, not really thinking about all these things that happen automatically. But it's very sad when some people are not able to consume food regularly like they normally would. So don't take it for granted. Um, the process is a very complicated process. People that have a stroke, at one point they were eating just fine, just like you and I, and all of a sudden they have trouble swallowing. Okay, they have trouble swallowing. We call it dysphagia. Dysphagia is the inability to swallow safely, right? It goes into the lungs. You don't want it there. You want it to go into your esophagus. So then they can't eat safely because they might choke or aspirate, or get food or liquid into their lungs, and they get aspiration pneumonia, which we'll mention a little bit later on. So they get this problem. So how are they going to eat now? well, they're probably going to end up needing some kind of special diet, maybe a puree diet, or maybe even a feeding tube. People that develop cancers in their esophagus or in their stomach also have a high risk of nutritional deficiencies or nutritional problems because either there's obstruction, okay, or pain, or some other way that they cannot, have food come down into your esophagus and in your stomach. So that's another possibility. People that have temporary procedures. I know some people are nowadays are going for the gastric bypass. It's a major surgery, guys. There's a lot of people that are going through that. I think sometimes, and they go here to the across the border to Mexico, and they get it done. And we honestly, at this point, I don't think everybody, the doctors, don't really know how people that are getting gastric bypasses are gonna make it through them in their later years. Okay, why do I say that? Because as we get older, your everything slows down, including your GI system. So if you have a stomach this small, okay, and then uh, as you get older, it slows down even more. How are you going to be able to get nutrients? So that's a problem that I foresee coming in the future. But anyways, so I pretty much covered the the GI system, right? The the anatomy and so on. So you can get a good understanding now. What are you going to be talking about today? We're going to be talking about enteral nutrition, and then there's another term called parental nutrition. So enteral nutrition refers to the process of introducing nutrients, okay, nutrients, not necessarily food, just nutrients, into the body through other routes that is not oral, okay, not necessarily the normal route. So explain why internal nutrition is the next best option. Well, as I said, if you are unable to chew food or taking food like you normally would, how are you gonna be able to survive, without nutrients? Or you can't. Okay, so you must meet your nutritional needs some way. So it's very important that we find a way to give you the nutrients. Some people will require nasogastric tubes. Some people will require gastrostomy tubes. Some people require jejunum tubes, or some people might even get their nutrition through their IV. So it just depends on the condition of the patient, the situation. All right. So why is it important? Because if you can't get food orally, okay, the regular route, then you will not be able to meet your nutritional needs. If you can't eat right, then of course you're going to start to lose a lot of weight, and your immune system goes down. You start weak, and you may even get dehydrated. So there's a lot of complications that can occur if we do not meet our nutritional needs. So enteral nutrition is one of the most common ways that we utilize to meet the nutritional needs of a person. One of the procedures that you can be familiar with is insertion of a nasogastric tube. Now, this may or may not be in your scope of practice, and some facilities that won't allow you that, but it's a fairly simple procedure to do, very uncomfortable, but it can be done. It's a aseptic technique. It's not a sterile technique procedure. Uh, I'm going to show you a small video, hopefully that you can see how it goes. Let me see if I can find it real quick. Mhm. Any questions so far?
No.
There's a lot of kids that don't that have feeding tubes.
That's another one.
I know there's a lot of kids that are out there that are born with some kind of problem, nutritional problem, or they're very small. They have a problem eating food. Okay, here it is. Let me share the screen here.
Estimate the length of tube to be inserted. Note markings on the tube where the tube should exit the nostril. Gently insert the NG tube through the nostril at an angle parallel to the floor of the nasal canal. Pass the tube along the floor of the nasal passage, aiming down toward the patient's ear. Continue inserting the tube until it is just past the nasopharynx. Advance the tube with swallowing. If fluids are not permitted, instruct the patient to swallow and advance the tube during the swallowing motion. Advance until reaching the tape or mark on the tube. Attach a syringe to the end of the tube and aspirate gently to obtain gastric contents.
Okay, I think the guy forgot some steps. So before we insert the tube, obviously we need a physician's order as to why we're putting this tube in. This is an invasive procedure, so obviously we have to obtain consent from the patient. After they obtain consent, then we have to get a kit. Well, it's not even a kit, it's just the tube by itself, a nasal gastric tube. And the way we measure it is that we measure from here, from the nose to the back to the ear, and then all the way down to your stomach, right? It may be about, I don't know, 18 inches more or less that we're going to be inserting. So we put a piece of tape to mark it there, because that's how we know how far we're going to put it in. So once we get the measurement, okay, we usually curl it up. You know, we curl it up in our fingers to bend it, because it's very stiff. It's kind of thick tube, actually. Okay, it's not small, it's kind of thick. We curl it up to make sure that it's kind of curved this way. So when you insert it, it's not going to be straight, you know, pointing like that, but it's a little bit more curved. And if I'm going to insert it on my right nair, okay, I'm going to be pointing it toward this ear. So when I point it this way, the tube starts going down to the back of the mouth. And once it reaches the back, right, the back of the throat, the person starts gagging, okay? So when they start gagging, right away you stop, okay? You reach the back of the throat. So if they open their mouth, you're gonna see the tube in the back. So at this point, as the video did say, if they can have water, you can just give them with a straw and they can swallow. What is it that you're trying to do? What you're trying to do is for them to open up their esophagus, okay? Your esophagus is here, and there's a little, like a little, like a valve, right? Like an, it opens, it's called the epiglottis. The epiglottis opens and closes every time we're gonna eat, or if we're breathing, obviously it closes, right? And you breathe, opens for food. So when they swallow water or saliva, if they can't drink water, they swallow and this thing opens to allow saliva or whatever it is. And once it opens, then you're gonna push the tube in, right? And it's gonna go all the way until you reach that piece of tape that you place on the tube, okay? Once you're in there, you're gonna hear some kind of crackling sounds like snack, crackle, and pop. Or you can get a syringe, like one of those big, thick syringes. You call them a septo syringes. You get one of those, insert it, and we aspirate. We can pull on it, and we're gonna see gastric acid, right? So if you get gastric acid, you know that you are in the right place, okay? How do you know if you're in the wrong place? The other direction you can go into is that you can go into the lungs or into the airway. Well, if you go into the airway, guys, okay, the patient will start choking right away. They'll start coughing. Just like when anything goes into your airway, start coughing right away. Okay, so right away you should probably retract it and try one more time, swallow saliva and push it down into this esophagus. So that's where you're trying to go. So once we insert it in there, okay, the tube goes into the stomach. We know there's gastric acid. We know we are in the stomach. We have to secure it down here. We usually put tape around here. We clean it with alcohol to remove the oil, and then we put a piece of tape, transparent tape here, and then over the tape we're gonna put another smaller piece of tape and secure the tube onto the nose, okay, onto the outside of the nose. Because the tube can actually be moving in and out, okay? So that piece of tape that you put in there, it tells you if the tube is moving out, right? It usually doesn't move in anymore, but it can come out. Your body will start to push it out. So that piece of tape is very important because, again, if the tube starts to come out, okay, it can actually travel up into your airway here, and the food can start going into the lungs, and they can aspirate or choke. So it's very important that we keep track of that tube, make sure it doesn't move in and out. Well, once the tube is in there again, now we can administer medications, we can administer nutrition, water, whatever it is. Sometimes we insert these tubes not for nutritional needs, but for other problems. We call it decompression, so that we can relieve a lot of stuff that it's maybe in the stomach. We stuff that needs to come out. We can also take it out that way. But in this case, we're talking about nutrition. So nasogastric tubes are a temporary. Remember this. It's a temporary method of providing nutritional needs. Okay, why? Because the risk of them aspirating with a nasogastric tube is very high. Right, so it's really important that when a person has a nasogastric tube, you have to make sure that the head of the bed is always at least 30 degrees elevated. Okay, you cannot have bed flat because they will aspirate. Whatever you put into the tube, it can come back into the lungs. Remember that when you put the tube in, you're bypassing the sphincters in your esophagus, right? So anything in your stomach can just come right back. Okay, that's why it's very important that we maintain the head of bed at least 30 degrees, if not 45 degrees. To me, it's safer to keep them at 45 degrees to prevent aspiration. All right, so what is the name of a tube that is inserted through the nose? What do we call it? We call them nasogastric tubes. Okay, nasal means nose, gastric means stomach. So nasogastric tube. Again, this is for temporary use of nutrition. Now, there's other tubes that most commonly you're going to be seeing. These are called uh, PEG tubes. PEG tubes. PEG, PEG stands for percutaneous endoscopic gastrostomy tubes. These are for temporary or permanent use. So you can leave them on there, for a month, 2 months, and then later they can be removed. Some patients can have them there temporarily because of maybe they had a surgical procedure that they couldn't eat or, through the normal route. And after they heal, everything goes away, and then they start eating again normally like before, then that tube can actually be removed. So it could be a temporary or it could be a long-term use. That's one of the things that some families don't understand sometimes, that they can be used both. Sometimes patients, when they stop eating or they start losing weight, maybe they're on chemotherapy, they have cancer, not necessarily of the esophagus or the GI system, but they're just not eating and they're losing too much weight. The doctors may suggest a feeding tube. Okay, the person can still eat orally, but they may benefit from having additional nutrition through a feeding tube. So they can have both sometimes. It just depends again on the condition of the patient. So a surgical incision usually in the stomach is called the stomach itself called a gastrostomy. Okay, gastro is stomach, ostomy is artificial opening. So this is a gastrostomy. This procedure is done very quickly, very easily in the GI lab by a specialist called a gastroenterologist. They do it in a matter of 20 minutes. Okay, they introduce an endoscope or camera into the esophagus and into the stomach. They puncture a hole out to the surface, and then they introduce the tube into the stomach. They inflate a balloon just like the Foley's you saw, and then the tube doesn't come out, and then we can insert. So these tubes again can be used for a very long time, very commonly used. Again, you still have to perform what we call aspiration precautions. Remember, keeping that head elevated at least 30 to 45 degrees at all times. So if you're working with a patient or a resident that has a feeding tube, make sure that when you leave that patient, they always have the head up, okay? Now, some facilities do not allow nursing assistants or patient care techs to turn the machines on or off, okay? Because if you forget to turn it back on, right, the person may go without nutrition for an extended period of time. And if they're diabetic, they may have complications. So it's very, very important that you know or remember to turn it back on if you do turn it off. The other kind of tube that you might also see that is also goes in there, it's in the stomach. It's called a jejunostomy. So I mentioned this part, it's closer, it's actually in your small intestine. A jejunostomy tube is placed for patients that have a very high risk of aspiration. Maybe they move in bed a lot and they're always, going in the flat on their bed, or they have a lot of vomiting. Maybe they can't tolerate the feedings. They might be candidates for a jejunostomy tube. Now, these tubes are very thin. They're very small. They're surgically placed in the small intestine by a surgeon, not necessarily the gastroenterologist, but the surgeon. So these tubes are very small. Although they have this safety feature or benefit, they're not very commonly seen. You don't see them very often. So if you see a very small tube, it almost looks like a catheter tube, okay? The surgical implant there, that's where they get their feedings, okay? So gastrostomy, you see them more on your upper quadrant, and then the jejunostomies, you can see them a little bit more on the right lower quadrant or right upper quadrant. So very, very different looking tubes, but they're both for the same purpose. Now, there is some, I guess, complications with the jejunostomy tube because your stomach is not participating in the digestive system. The nutrition that the person gets through a J tube or a jejunostomy tube is a little bit different. It's more broken down because there is no gastric acid, and there's that those electrolytes that are in the stomach, the food. So you may administer these feedings. Okay, the feedings. How do you administer them? Well, there's many ways. One of the most common ways is with the use of a pump. These mechanical pumps that actually you connect the bag on there and you set it up. They add water to it, and the pump just keeps going. It adds it gives the patient a continuous feeding. Okay, over 24 hours, or sometimes they're given over 12 hours, maybe 4 p.m. to 6 a.m. in the morning, or whatever the nutritional needs of the patient are. So they could be continuous, they could be intermittent, or they can be either given as a bolus feeding. A bolus, as the name implies, like a bola, like a large amount. It requires that you use an aseptic syringe. Those big syringes, you connect it to the peg tube, and then you drop the can, right? The can feeding, you just drop it on there into the stomach, directly into the stomach. Some patients can tolerate this. Some patients cannot tolerate this kind of feeding. It's too much, okay? And then they suffer from diarrhea. Okay, it's called dumping syndrome. But anyhow, bolus feedings or via the machine is another method of administering medications or nutrition in this case. So they could be intermittent, they could be continuous feedings or cyclic feedings. Sometimes we like I said, we plan the feedings for a particular time of the day, and the rest of the day, maybe in the morning, they can actually eat orally. I've had patients that can do that. They puree food, and then they get also a peg tube feeding or combination. The food, the nutrition comes in cans. It comes in bags, which is very, very easy, or something that looks like a huge bottle. Okay, we have to spike the bags. It doesn't spiking means we screw it on or we put it in there. It's like a little spike. You put it in the bag and it just flows into the tubing to the machine. So it's very, very they're very handy, very easy to do, guys. Again, you may be in charge of doing this at some point. So now that you're a little familiar with this kind of alternate nutritional methods, you should actually try it at one point. So care measures. How do you care for these persons? Aside from the nutritional needs, they're also going to require oral care because they're not eating orally anymore. A lot of the times their mouth becomes very dry. They may or may not be able to perform their own oral care, so we have to help them out and make sure that their mouth is clean. And believe it or not, before oral care was non-existent, CNAs would not do oral care on this person. Just, well, they're not eating through the mouth, so they thought there's no point, or they were maybe just lazy. But we have to perform oral care, make sure that, just like, or help them with oral care if they can do it themselves. Very, very important. Their bowel movements are very important that we monitor. A lot of them get constipated with this this type of nutrition. They get constipated a lot. Okay, very, very often. because they don't move, they're just laying around in their bed, they're sedentary. And constipation is a very severe problem. But also sometimes they get a lot of loose stools, not necessarily diarrhea, but they go very loose or sometimes watery. So we have to monitor their bowel movements. I have several patients that have feeding tubes, and I always have to make sure that they go as normal as they can. But we record bowel movements on a regular basis, either in small, medium, or large amounts. Preventing complications, the most serious complication that we have with these feeding tubes is aspiration. I said aspiration is food or liquid going into the lungs, okay? The food or liquid does not belong in the lungs, okay? Only air belongs in your lungs. So if food or water goes in there, you start, they may not even cough, okay? They may start to develop infections, and they call it aspiration pneumonia. It's a very serious complication. And sometimes it's not obvious. It's not obvious. Sometimes it starts very slow, and then later they start to develop aspiration. Healthcare associated infections, not too common unless we don't practice good hygiene, hand hygiene, like washing your hands and wearing your gloves and all that. We have to make sure that we use gloves because we may come in contact with some kind of body fluid like gastric contents. Dehydration is a complication also of feeding tubes. So we have to make sure that we provide adequate amounts of water. Either we give it bolus, like with a syringe, or some of the machines that are now out there, they actually are able to give the water. So we have two bags. We have a bag for the milk, and then we have a bag for the water. So what the machine does is that it'll alternate. Okay, it'll give so much such amount of um, of water, and then or milk rather, okay, and then like every 4 or 6 hours it'll stop, and then it gives them like a cup of water, okay, something like that. You can program the machines any way the physician wants to. So dehydration, again, look at the oral mucosa, look at the tongue. If it's shiny and moist, he's fine. If it's dry, then the person is not getting enough um, hydration or water fluids. Dumping syndrome, I mentioned to you right now what it is. It's pretty much diarrhea. Okay, the person cannot have bolus feedings. Just dump in a can in there. They cannot handle that, so they get diarrhea. So what the solution to that is usually put them on a feeding pump. The feeding pump will slowly feed the nutrition over 24 hours or a cycle, whatever the physician requires, or whatever the patient needs, whatever the nutritional needs are. All right, the next kind of nutrition that is not a tube, is not a nasogastric, it's not a peg tube, it's not a jejunostomy. They're called parenteral nutrition. Parenteral nutritions are getting nutrients through the vein. Okay. Now in this case, this is probably not in your scope of practice, but just so you know, okay, parenteral nutrition is given to patients that cannot eat or swallow safely, or they cannot digest food for some reason. Maybe they had a colon surgery or some other kind of procedure done that that their intestines, their JC, some need some kind of rest. They're gonna benefit from getting parenteral nutrition. So it's food in a bag. That's what it is, right? And it's going to go straight into your bloodstream via a central line, okay, which is inserted in one of your larger veins, or even a PICC line. The PICC lines are the ones that insert it, distally, more on your arm, right here, okay, and they go here all the way into your heart. So it goes into your bloodstream, and it goes into your heart, and then it gets pumped around by your heart through all their body. So parenteral nutrition is only meant to be used temporary. You cannot have this nutrition for a very long time. Number one, because it's very, very expensive. One bag of nutrition, it's about $2,000 a day. So that's eating $2,000 of food per day. All right, so number two is that it has a high risk of infections because it has a lot of sugar in it, in the bag. It has a lot of glucose that we need. It has fats, it has proteins, and every other nutrient that we need. It can carry a high risk of infection on the central lines. That's why many times they're used only for a very short period of time. So those are total parenteral nutritions, and again, they usually, it looks like milk. Really, it does look completely white. It looks like milk, but it's administered only for a very short period of time. We have to make sure we check the glucose levels, right? the glucose levels are checked at least every 6 hours to make sure that their sugar is not too high, because the milk is going straight into your bloodstream. Okay, so the blood sugars are going to spike. Okay, so we want to make sure that the person is not, having very high blood sugar levels that can create other problems. Okay, so you may be responsible for monitoring these glucose levels. Okay, every 6 hours. Um, we want to make sure that the pancreas it's producing enough insulin, that there's enough glucagon produced by the pancreas, and so on. So again, there's electrolyte levels done every single day on this person to make sure that all the nutrients are within the normal therapeutic ranges. So again, giving parenteral nutrition is not just about connecting the person to the milk and that's it. There's a lot of other things that come into play, such as monitoring blood sugars. And I don't think we practice that here. It's a capillary stick. Okay, it's very easy. I think you've probably seen maybe somebody in your family check their blood sugar levels. You would do it the same way, except, as you know, phlebotomists, we always wipe off the first drop of blood and then get your blood sample. So remember that when you're going to be using a glucose monitor, make sure that you do a quality control test, okay? And that's usually done by the night shift. So when we come around in the day, we know the machine's already checked, they're accurate, right? We rely on those little devices to make sure that we get good readings, because that's what the doctor uses to adjust the treatment. Okay, at this point, I'm going to